I'm going to present a case, an evolving case, basically. It might be very good to follow from Dr. Wilson that he showed us the evidence of using multiple modalities in treatment of cardiogenic shock. So I'm just going to dive into the case. So a 32 years old gentleman. He is deaf and mute due to neonatal meningitis. This gentleman had his brother as interpreted. He is known to have non-ischemic cardiomyopathy. So ejection fraction was about 20 to 25%, and also known to have moderate to severe MR that was diagnosed 3 months prior to his presentation. There also a family history of sudden cardiac death, as his brother died at the age of 20 due to dilated cardiomyopathy. So he presented to the emergency department basically complaining of shortness of breath, cough, frothy sputum, orthopnea BND. There was no contact with the sick patients, and he was compliant to his medication. So his medication at the time presentation was, he was on Lasix, he was on Entresto, empagliflozin, spironolactone, and other medication for his heart failure. So in his vital, when he presented that he has low blood pressure, 83/52, quite tachycardic at 123, low grade V4, respiratory rate about 30, and his oxygen saturation was still okay, 97% on room air. There was the stress, cardiovascular examination revealed the gallop rhythm, there was basal crepitation, raised JVB. In the emergency department, they basically gave him IV bolus. Because of low-grade fever, they sent for septic screen, they started antibiotics, and they referred him to cardiology. This is his chest X-ray when he presented. His troponin was mildly elevated, 177. His BNP was more than 35%. So clearly acute decompensated heart failure in a patient who has non-ischemic cardiomyopathy heading toward the cardiogenic shock. His renal function is impaired now. It doubled since last visit. His potassium is high, so element that is clearly that he's hypoperfusing. There is no transaminitis that is significant, and his lactate was 7. Chest X-ray, as you can see, there is clearly bilateral bilirubin, more on the left side. There is also interstitial edema. It's hard to say that if he has aerospace disease, but based on this X-ray, you can conclude this picture. This is a patient with acute decompensated heart failure heading toward cardiogenic shock. So if you look at SCAI stages of patient with cardiogenic shock, where this patient will fall, he will be falling into a classic, who is a patient who has clinical evidence of hypoperfusion, there is renal failure, there is lactate that is elevated, and this patient would require pharmacological or mechanical support. That will depend on the discussion. So cardiology got involved. They gave him Lasix, and they held his beta blocker, and they initiated medication, admitted to CCU, and Levofed was started. So we just talked about, Dr. Wilson talked about the importance of cardiogenic shock team or shock team, and we do have in our institution our own team which comprised of cardiologists, interventional cardiologists, cardiac surgeon, heart failure specialist, and also the intensive care, which is in this situation cardiovascular ICU. And normally this will be activated, the shock team will be activated if a patient is labeled to have cardiogenic shock and is deteriorating, and those who have the cardiogenic shock should have sign of hypoperfusion, and that either if they have lactate more than 2, if they have decreased urine output, or if they start to be on 2 inotropes. So if that's the case, the team will be activated. The primary cardiologist who's seeing the patient will decide if this has to be discussed with the rest of the team, or this could be managed medically. So if they decided that we have to move forward, then the whole team will convene. If it's during the daytime, will happen. If it's after hours, they will do it by a phone call or a Zoom meeting, and a decision will be either to continue medical therapy or to escalate to mechanical support or surgical mechanical support. So this patient, after initiating Levofed, his blood pressure improved, he still has cold extremities, his creatinine improved, potassium improved, and his lactate started to drop down. So this is it, chest X-ray, still has interstitial edema, bilateral pleural effusion, but then his condition is general is great. They changed his Lasix to IV and started him with dobutamine, and you know, just the regular care that we offer a patient in CCU settings. Over the next 24 hours, his blood pressure remains stable. He's doing okay. His dose of levofed and dobutamine will start to come down. And then when start to wean the levofed, his creatinine start to go up, and his lactate start to slightly go up as well. This is his baseline echo. As we can see here that there is a large left pleural effusion. There is dilated cardiomyopathy with evidence of moderate to severe MR. And you could see also that there is a tricuspid regurgitation, and the IVC was not collapsible. So a picture suggestive of a patient that has chronic dilated cardiomyopathy. His angiogram confirmed that there is no evidence of any coronary artery disease. And he did have a right heart cath just in the next 24 hours, just to lay basic the information for him. At that time, he has just mildly elevated right atrial pressure. There's mildly elevated pulmonary hypertension, and the which was borderline, and his cardiac index was 1.79, so less than 2.2. His BABI was just borderline, more than 0.9, so 1.14. And his perivascularism was okay. The Swan-Ganz was left in place. So on the third days, he was doing okay, but they started switching dobutamine to milrinone, and they weaned down his levofed. On the fourth day, he started to deteriorate again. His lactate started to go up. And if we look at Intermax for cardiogenic shock, he's still at level 3, who's stable but inotrope dependent. Since we withdraw the levofed, he start to deteriorate again. So the question comes in those situations, because this is a dynamic process, is where to go next. Are you gonna resume inotropes? We just saw the slide showing that adding inotropes actually worsen mortality at the long term. So would you consider that? We know that he's dependent on it. Should we consider mechanical circuit support? Should we look for other causes? All those are vital questions that you need to ask and you need to try to determine. So the question at this time is just basically a discussion of where to go next. And the team at that time, looking after the patient, decided to just offer him the simplest form of mechanical circuit support, which is basically intra-aortic balloon pump. You know, until recently, there is no clear evidence in the literature. There is observational trials suggestive that intra-aortic balloon pump does work. We know in patients with acute cardiogenic shock due to MI, there is no utility of intra-aortic balloon pump from the SHOCK 2 trial. But in patients with heart failure, cardiogenic shock, is there any utility? So the utility just being confirmed recently that it's not there by the ALT-SHOCK 2 trial, where they basically looked into heart failure patient who has basically cardiogenic shock, and were randomized to intra-aortic balloon pump versus supportive care, and this was published in March of this year in 2025 at JACC, and it showed basically no benefit, and the trial was stopped early due to futility. So on day 5, actually after putting the intra-aortic balloon pump, again is what suggests it actually the patient did improve significantly, heart rate stabilized, everything is stabilized, and septic screen came back to be positive for influenza A, which could be the trigger in his situation here. Day 6 and 7, the intra-aortic balloon pump was weaned up, but then later on he developed acute ischemic legs, so he had to go for surgery and underwent emergency lumpectomy, and IV anticoagulation was initiated. Day 8, patient again become very sweaty, tachycardic, heart rate around 150, his lactate is 3.5, he has urine output dropping, and he's tachypneic and hypoxic. So clearly this patient is going in and out of cardiogenic shock. Whenever you're trying to fix him, he gets better. When you try to withdraw care, he becomes decompensated right away. So a CT chest was done because we were looking for other causes why this patient deteriorating, and there was element that since he had this clot in his arterial system, he tended to be hypercoagulable slightly, so there was element also of small subsegmental BE and segmental BE, and he was already initiated anticoagulation. His milrinone was increased, and levofed was restarted. The patient now is no longer at classic stage C, but now he's moving up the stage of Sky classification. He's deteriorating. So he's a cardiogenic shock, and despite the treatment you initially offered him, he's deteriorating. And again, he's sliding. He's at level 2 intermax, which is basically sliding while he's on inotrope. So SHIC team got activated, and decision now is, if this patient deteriorating, is to escalate therapy. Looking at danger shock trial, that intra-articular pump, one of the things that worked, but that was in acute MI. But still, since this patient has a clot in his right femoral artery, the idea is to consider a small profile mechanical circulatory support. So he was taken for an for Ambilla. And the lactate, when initially started, was 6.2, but despite placing this patient on Ambilla, actually there was no improvement. Actually, he got worse. His lactate reached 12.4. And the reason for that, Ambilla works beautifully in patients with isolated LV dysfunction. If you have a biventricular failure, Ambilla is not your friend. Ambilla is your enemy. You should not consider it in those situations. And this patient did have biventricular failure. It was borderline on the right side, but it got worse because you don't have no forward flow. And that time, we escalated this patient for an ECMO, and we did consider, we did add an intra-articular pump of venting, but we had to do it carefully because of the recent intervention on the right femoral artery. And after that, you could see his lactates start coming down all the way to 1.5. The patient did well over the next 3 days. The ECMO was removed, and his blood pressure stabilized. All the inotropes were stopped over the maximum of 8 days. There was no signs of sepsis, and the patient was basically stabilized and sent home. So the take-home messages in this situation, just give me 30 seconds, please. Don't. Yeah. So cardiogenic shock is dynamic. In cardiogenic shock in patient with acute heart failure, is a bit different from acute MI. Can we just get this last slide? And because it's a dynamic process, you have to go forth and back and trying different things until you try to stabilize your patient. And early recognition is very key for treating those patients, and rapid shock team activation is very important in this situation. MSC, mechanical circuit support options are available for you. There's not a lot of great evidence to support the use of them, but we are compelled, unfortunately, as a physician who deals with those patients, is to offer them what we can. And sometimes it might not benefit, but if it's, we err on the side of caution, so we give them what we can. And it is very important that you have to be very vigilant about the rapid changes in those situations. That was a case of acute heart failure, cardiogenic shock, not related to MI, which is a bit different, and not one of the things that we deal with usually as an interventional cardiologist. Thank you.